Okay, we're going to go ahead and get started. We want to be cognizant of everyone's time today. So thank you for joining us. We are here, and special thanks to Saladex for supporting today. We're very grateful to be here to talk about using rapid clozapine blood levels to improve patient management. So I'd like to go over a few housekeeping things before we make introductions. Handouts are available. You should have received them on the way in. Oh, and I forgot my book. So in the handouts, in the back of the book, there is a submit a question on the side. So if you guys have questions, go ahead and rip that out. We have teams that will be coming around to collect those to get your questions answered. Also, there is a survey to complete. We would be very grateful if you took the opportunity to do that. Also, you could leave your email. We will be compiling all of the questions that are asked today, and we will send out packets to anyone who submits their email. The information that we're presenting today is based off the feedback we received from last year, so it's very helpful and informative for that. Additionally, in the handout, you will see that there are 3 mini webinars forthcoming. The second one is decided by you today. So if there is something that you are missing and would love some education or information on, please send that along because we will go ahead and get that webinar all set up. Virtual attendees, just so you know, I will be showing you an email during the question and answer session where we can submit your questions online as well. We won't be able to answer those today, but we will be making sure that we get all of those answers out to everyone at the end. So I'd like to take a moment and introduce our speakers today. So I'm Megan Arrett. I'm a faculty member at the University of Maryland School of Pharmacy, past president of AAPP. I'm very excited to be here today. I'm joined by Dr. Jonathan Leung. He's our very own Jonathan Leung, our expert on clozapine. Did his PGY2 with our very own Erica Krause in the audience at VCU, practices at Mayo Clinic, and he has numerous publications. Our recent case report award winner from yesterday on clozapine, so we're excited to learn from him today. Additionally, we are joined by Professor David Taylor from the UK National Health Service. I just want to give you a few of his highlights on his career because many of us haven't gotten the opportunity to work with Professor Taylor. Since 2010, he has been the head of the Pharmaceutical Sciences Clinical Academic Group within the King's Health Partners, and he's going to tell us all about his experience today. He was the originator of the evidence-based mental health prescribing guidelines, the Maudsley guidelines, and we have some fun prizes at the end for some lucky participants today, so don't leave early. This is the 14th edition of these guidelines. In 2014, David was named one of the top 100 clinical leaders in the UK National Health Services. He has over 400 papers and subjects ranging from the value of LAIs and many around clozapine that we're going to learn about today. And so I'm very excited to welcome both Jonathan and David here with us today. So with that, we will have introduction and objectives. We're going to go through the clinical practicability and benefit of clozapine therapeutic drug monitoring. David's going to give us his 30 years experience of working with clozapine and where they are today. And it's very interesting information about learning about the differences in the UK and the US. And then we'll transition to questions and answers. So the objectives for today's session are to understand barriers and approaches to the use of clozapine for treatment-resistant schizophrenia. We'll describe the utility of therapeutic drug monitoring for clozapine. We'll review therapeutic drug levels, clinical decision-making, and discuss some possible alternatives to TDM if it's unavailable at your site. So I'm going to turn it over to Jonathan, who's going to start us with a clozapine discussion.
Thanks, Megan, for that introduction. I'm really excited to be here. I work exclusively or part-time in a clozapine clinic, and I'm always thinking about how we can improve access, safety, and the effectiveness of clozapine. But as we all know, there's a lot of barriers to a patient getting a prescription of clozapine, having that monitored appropriately, and having ongoing care without them coming off of it for some reason. Today we're going to highlight a few cases that I've encountered in my practice that really highlight the benefit potentially of a rapid access to clozapine levels. Through some of these cases, we've been able to have our lab have quicker turnaround time, but still it may not be as quick as needed, as highlighted in some of the cases that we'll talk about. It'd be preaching to the choir to really talk about all the barriers of clozapine prescribing, but this 2022 publication highlighted really the deficit of clozapine prescribing throughout the United States. Experts in the field say we should be prescribing clozapine at about 10% of the market share, but you can see throughout the United States there's a great disparity. You may have seen the recent publication in schizophrenia research that is updated to this 2011-2012 data. The same underprescribing of clozapine continues, and they specifically call out a 13-fold variation of the highest prescribing state to the lowest prescribing state, with the Southeast having significantly reduced prescribing of clozapine, disproportionately also affecting Black and African American patients. So something really to think about the equitable treatment and use of clozapine in treatment-resistant schizophrenia. I think through the pandemic, we also learned about new barriers as it relates to the need for this monitoring. What happens if a patient's in quarantine and can't get to the lab? Working with the pharmacies to understand that if they've been on clozapine for years, there can be some variance in flexibility to what the REMS program kind of has put in place. Really throwing away that old thought or that motto the REMS program had of no blood, no drug. We have to move away from this, really collaborate with our community pharmacists to really ensure patients have access to their clozapine. Just as a curiosity, how many people since the pandemic or through the change of the new REMS system know patients that have had barriers to accessing their clozapine as effect to REMS or other factors? How many of those have led to significant harm or hospitalization? Yeah, there's a lot of hands in here. It's something that we need to work on. We need to work as an organization, other organizations, to help improve access and really overcome these barriers to shift a system that has been put in place to promote clozapine, recognizing that now it might actually be causing some harm. So as we think about how we can actually improve clozapine safety and effectiveness, therapeutic drug monitoring really should also come to mind. We do it with lithium, we do it with tricyclic antidepressants, many other medications. Clinical and TDM guidelines recommend and really suggest that therapeutic drug monitoring for clozapine just should be a practice. It should be something that we do, yet there's barriers to the lab itself, just from a practical standpoint of why maybe folks aren't checking clozapine levels. How many people routinely recommend clozapine levels for their patients? Okay. How many people have barriers to accessing quick turnaround of those labs? Okay. I always like to ask this question. What's your turnaround time on clozapine levels? Just yell out. 5, 7, 2 weeks? Yeah, right? So as you can see, how do we use a clozapine level when we're talking about safety if we need to wait 2 weeks? It might be reasonable as we're trying to maximize and improve clozapine from a therapeutic standpoint, but when we're talking about has a patient been taking it, is there toxicity involved in a patient admitted to the ICU, and how do we manage that? There's some clinical aspects that we need to take into account, and therapeutic drug monitoring certainly can help with that. The why, Professor Taylor is going to definitely delve into this in the literature, but really from the how standpoint is related to thinking about some of those barriers that are in place and how can we overcome those. Like I said, we were able to go to our lab, try to get a quicker turnaround time. We're on the verge of about 24 hours or a little bit less if we get it in early in the morning and only Monday through Fridays. Other than that, it may take even longer. Again, so we can't really use them in real time. The other issue is the send out. I'm assuming, 5 days, 2 weeks, you're sending those labs out. And again, if you need it right then, what is the practical aspects of not being able to have that lab? And so are you going to order it when you need it in those emergent situations? Most of us are probably familiar with those send outs, or if your hospital does clozapine levels. This is done by liquid chromatography, mass spec. And this is really the standard aspect of how most people are probably getting their clozapine levels. We'll shift a little bit and talk about later a novel immunoassay technology where we're getting clozapine levels in minutes that we can use in real time. So I'm going to highlight some of the cases that in retrospect, if we had clozapine levels in real time, we may have been able to prevent harm or reduce side effects of clozapine, starting with a 57-year-old non-smoking man with a history of schizophrenia. He was admitted to the hospital for worsening psychosis. The patient denied missing clozapine. Due diligence was had. They reached out to the group home, got that medication administration record. All the days were checked off. The patient had been taking it, and that medication was restarted upon admission. Shortly after that, the patient was found unarousable to painful stimuli. He was transferred to the ICU for monitoring of respiratory status. Following his improvement, the team probed after a site consult, and he said he was having hallucinations that were telling him to not take his medication, and he was diverting medication and telling his group home staff that, in fact, he was taking it. Ultimately, that level came back later, retrospectively, as a level of 0. So an example of a situation in which we confirmed adherence with the patient, their caregiver, and yet we still needed maybe a little bit more information to make sure that patient safely was restarted on their clozapine. The second case, this is what a benefit might be of having real-time clozapine levels to minimize dangerous exposure. A 30-year-old with a history of schizophrenia came to the ED with worsening respiratory distress over a period of about a little over a week. He was on clozapine, 500 milligrams at bedtime, and a level was drawn on admission. His respiratory status progressively worsened. The chest imaging showed pleural effusions that were extensive. This patient ended up going to the ICU. The clozapine level was drawn on Saturday. Delay in processing that level didn't come back till Tuesday, so that patient was exposed to a clozapine level of over 6,000 for those days. This is the highest clozapine level I've seen, but you may have other experiences of high levels. But again, in the setting of infection, maybe we could have preemptively decreased that dose, but again, would even 50% have been enough in this clinical situation, right? You would hold that dose. So again, another situation in which we have some respiratory status on top of an infectious process, a rapid level, or being able to use a level in real time would have been beneficial. And this gets to the case that I presented for the awards earlier this week. This was a 40-year-old non-smoking white woman with a history of bipolar disorder. She came to the emergency department having a manic episode, minimal medical history, history of hypothyroidism, her TSH was normal, and a history of tardive dyskinesia. She had been on multiple antipsychotics, mood stabilizers. They tried several things in the hospital, and because of the treatment-resistant mania, they opted to start clozapine, which started at 25 milligrams, a reasonable starting dose, and titrated by 25 milligrams every day. Again, from an inpatient standpoint, probably not an unreasonable rate of titration. She received 200 milligrams on day 8, was discharged the next day, and then seen in Clozapine clinic, where she was noted to have worsening sialorrhea, constipation. She had difficulty staying awake during the day, and dizziness. That dose was empirically reduced as we were waiting a clozapine level, which did come back at 1,500. This gets into probably some other aspects. As you can see, the CRP was elevated, and weekly CRP monitoring and maybe the role of that. But again, really highlighting, could a clozapine level been obtained when she was on 100 milligrams, right? Where we could have used it in real time to maybe alter the rate of titration, adjust that dose, and really not put a patient in a situation where they have a poor or negative experience of clozapine, which potentially could contribute to non-adherence and going off of a life-saving medication. So I want you to think about some of those cases. I'm sure some of these examples hit home with some of you and some of the cases that you've seen, reflecting on the point of, when would or could getting a clozapine level to be used in real-time practice have been beneficial. And so with that, we're going to shift a little bit to Professor Taylor, talking about his wonderful work with clozapine and his experiences.
Thank you. Now, I have a strange accent. Even in the UK, people say my accent is strange, so I'll do my best to make myself understandable to you. I'm very honored to be here in Atlanta, a city I know well because I've been watching The Walking Dead. It's rather different in reality, but better. So I'm honored to be here. I hope I can tell you something you don't already know by passing on to you some of my experience of working with clozapine over the last 30 years. So I have the privilege of working in what we think is the oldest mental health institution, which is the Bethlehem or Bedlam Hospital, which was founded in 1247, would you believe? It's moved around a few times. The current hospital is in its 4th location. I'm showing you the plaque from the first location and the second location, which is just on the north banks of the Thames in the old city of London. So I work at the Maudsley and the Bethlehem. They're about 8 miles apart in southeast London, or about 2 hours by car. And we have about 1,000 beds. We serve a population of 1.4 million. We have 60,000 outpatients, and we have about 1,600 patients on clozapine. We don't have any community dispensing of clozapine. It's all done by the hospitals, either on the hospital sites or satellite community sites that we have. So you'll know that clozapine is a pretty old drug. It was initially synthesized with a tricyclic structure following the success of chlorpromazine and imipramine and similar compounds. Initially thought to be a putative antidepressant, but found not to be. And so the company that had generated the compound, Wanda Pharmaceuticals, later Sandoz, sought other uses for it and decided that it would be a useful drug in psychosis, which it was. Nobody believed them, though, because it didn't cause dystonia or Parkinsonism. And in the 60s, of course, you had to induce Parkinsonism in order to be sure of giving the right dose of an antipsychotic. So it wasn't until the early 70s when anybody bothered to do an RCT, and it began to be used in Europe and 1 or 2 other countries until it was withdrawn in 1975, very famously, of course, because of the Finnish database identifying cases of agranulocytosis, all of which were fatal and all of which were associated with clozapine. Reintroduced in the US in '89, in the UK in 1990, to bring us up to date with 2023. I come in about there. Now, when I arrived at the Maudsley, we had a ward of 28 patients called the Special Care Unit, which is a bit of a euphemism for the most psychotic and dangerous patients unit. It was a locked ward of patients who had been extremely psychotic for a great many years, sometimes decades. They were all on huge doses of lots of different things. And a colleague of mine, late colleague of mine, said to one of the patients one day, there's a new drug called clozapine. We'll give you a pack of cigarettes if you start taking it. Things were different in 1993. So the patient said, yes, that's a good idea. Next day, patient approaches psychiatrist. Why haven't I got cigarettes? Can I have the cigarettes if I take the drug? Yes. Eventually, all patients on clozapine, 3 months later, special care unit closed because all the patients have been discharged. So these are patients who, I've already mentioned, had been very ill for a very long time, and all of them got better such that they could be discharged. Now, we wouldn't expect that kind of across-the-board response to clozapine now because treatment is rather different, but we used to think of people with that kind of condition, that kind of long-standing condition, as having clozapine deficiency. And we have a unit on the Bethlehem site, which is a national referral unit for the most ill patients with schizophrenia. And they all come to that unit and either have clozapine started or have clozapine optimized. And I'm here really talking about optimization of clozapine. So you don't need me to tell you that clozapine is supremely effective in treatment-refractory schizophrenia. Nothing else comes close, despite some studies that have been published in the last 20 years. But of course, it's criminally underused. And I thought carefully about what words to use to describe its underuse. And I think criminally underused probably captures it best. I don't know another area of medicine where the most effective drug is so widely withheld from patients who would benefit from it. A little while ago, I and some colleagues from around the world tried to establish what was happening with clozapine use, whether it differed across the world and whether it was changing. It was changing between the years 2005 and 14, gradually increasing, but there was a huge difference in usage measured in number of patients per 100,000 population. So Finland, ironically, had the highest usage. Japan had the lowest usage. You have to be admitted for 6 months in Japan to start clozapine. So that's a barrier to starting it, I suspect. US private, right down at the bottom, US public isn't very much higher. I think it's third or fourth bottom. And listening to the lecture on REMS yesterday, I noted that your use of clozapine has gone down since this study was published. So to update the view of clozapine use around the world, some colleagues and I looked at the frequency of clozapine prescribing, tried to match it against healthcare spending and what we call the stringency of regulations surrounding clozapine use. So this is a combination of the frequency of monitoring, what needs to be monitored, what monitoring is demanded, what rules there are about restarting and re-exposure, and so on and so forth. Now, this is an interesting figure because if you look at the bottom, it says that red indicates the highest stringency and yellow the lowest stringency, whereas red and yellow don't appear on the figure at all. But I think you can work it out. Highest stringency is orange and lowest is blue. And there's a huge difference around the world. What you can't capture here is the stringency that's inherent, I now know, in the REMS system. So the US seems to be a low stringency country, but of course the regulations as they're applied make clozapine extremely difficult to use. What we found was that as health expenditure increased, use of clozapine went down when you looked at it per country, and there was something of a relationship between clozapine use and stringency index. Again, as you might expect, the more stringent the regulations, the less clozapine is used. And we've known for years, decades, that clozapine is hugely underused. In my own unit, we found that the average delay in starting clozapine in patients who'd actually received clozapine at some point was 5 years. And these are data from the year 2001. We repeated the study in 2010, and the delay, I think, had slipped to something like 48 months. So it hadn't changed very much at all. And I suspect even in a unit that has well over 1,000 people on clozapine, we still have a significant delay between the time when somebody could benefit from clozapine and the time when they actually get prescribed clozapine. So we kind of have an accepted view of the history of clozapine, but there are elements to it that I think we would do well to remember, or at least note. We know that clozapine is associated with agranulocytosis. We know, in inverted commas, that it's associated with neutropenia. In fact, neutropenia and clozapine are words that don't appear together until 2 years after the original report of agranulocytosis. So the idea that clozapine causes a range of blood dyscrasias which include neutropenia which stops short of agranulocytosis and agranulocytosis is a very widely held idea, but is actually false. Clozapine doesn't cause neutropenia. I'll explain why. So again, this is something you don't need me to tell you. Clozapine-associated blood dyscrasia is hugely overdiagnosed. When you are told about the rate of agranulocytosis on clozapine, the assumption is that anybody who gets a neutrophil count of 0.5 or below, sometimes below 0.5, has a clozapine-induced agranulocytosis. That is not true. That assumption is incorrect. If you look at population prevalence studies, the rate of neutropenia varies between about 0.8% in Caucasians and about 4.5% in the study I'm thinking of, African Americans. 4.5% of people in prevalence studies in the general population who are of African descent have neutropenia. When you look at agranulocytosis, it's about 1 in 1,000 white people, Caucasians, and about 1 in 200 African Americans. When we monitor clozapine, we are effectively doing repeated point prevalence studies. So we have a thing called surveillance bias, where we keep picking up things that we'd never notice had we not done the test in the first place. And one of the things we pick up is neutropenia, which probably, in my view, undoubtedly has nothing to do with clozapine. And we also pick up rogue, low neutrophil counts, which might officially constitute agranulocytosis, but are not dangerous to the patient. And these are mainly in people with benign ethnic neutropenia. So in the top right of this slide, there's a paper that we published last year which describes a distinctive pattern of neutrophil count change in true clozapine-induced agranulocytosis. And here we see a catastrophic fall in neutrophils to 0 or near 0, which doesn't change even if you stop clozapine until you give GCSF. So you get this almost L-shaped curve where the fall from normal neutrophil counts to 0 is between one count and the next. And it was interesting to note that in no case of true agran with clozapine was there a neutropenia stage. So neutropenia doesn't seem to be a prelude to agranulocytosis. In every case that we examined, the last level before under 0.5 was above 2. So this idea that clozapine causes neutropenia and that might develop into agranulocytosis is probably also wrong. We know that we overdiagnose clozapine-induced dyscrasia because when you look at people who are re-challenged, having had clozapine stopped because of blood dyscrasia, success rates vary between 80 and 90%. That's the success rates. So people who have been identified as having a clozapine-induced blood dyscrasia, if they're re-exposed to clozapine, the vast majority of them can do so entirely safely, indicating that the diagnosis initially of a clozapine-induced problem was wrong. And again, some of this comes from the failure to diagnose benign ethnic neutropenia, which in the bottom right is a study we did recently in 2 centers in the UK, showing that on average it takes many years for benign ethnic neutropenia to be identified, and in one case it was 16 years. Most cases of benign ethnic neutropenia are identified or classified or diagnosed after a patient has had a red result on clozapine, not before. So I'm here to talk about rapid clozapine plasma level determinations, TDM. Why do we do TDM? You know why we do TDM with clozapine, because it satisfies all the criteria for doing TDM. The dose we give doesn't match the plasma concentration we get, and the plasma concentration is related to adverse effects and efficacy. There are lots of interactions to keep us interested and to keep our attention, and there are physical conditions too which alter clozapine plasma levels. So here's a graph of doses of clozapine and the plasma levels that result, and you can see that they're all over the place. If we just look at people on 600, you can see that their levels vary between about 100 and 1,300. So there's a huge range of plasma levels that arise from the same dose in different people, and that's because metabolism of clozapine is, as you will know as well as I, varies according to a number of factors, including gender, smoking status, so on and so forth. So we've got this huge variation in plasma level from the same dose. We've also got the association of plasma level with adverse effects. So here we have 2 graphs looking at EEG changes. one matching EEG change to dose, another to plasma levels, and you can see on the right that the plasma level graph is much tighter. I'm amazed that we still work on the idea that doses above 600 milligrams a day of clozapine are the signal for prescribing anti-seizure drugs, based on a study that was done in 1994, where patients didn't have TDM done. And we know little more about the patients other than the figures given to us. But it was also evident in that study, and as it is in this one, that the risk of seizures is related to plasma level and dose, but there isn't a threshold at which seizure activity begins. We have to decide on a point where we should institute some kind of anti-seizure medication, which is the best balance of several factors. So plasma levels also associated with lots of other things: rise in triglycerides, heart rate, variation, adverse drug reactions combined. There's a whole list on the left here of side effects that have been related to clozapine plasma levels, including constipation, paralytic ileus, colonic hypermotility, which all of those are pretty much the same thing, of course. And then there are other side effects which aren't plasma level related. So we have this situation where we can't predict the plasma level from the dose, so we need TDM to make sure we get the right plasma level so that we don't poison the patient. But also on the other side, we have to get the right plasma level so that we have the best chance of eliciting a response in the patient. And we all know that the threshold for response is 350 nanograms per mil, but it isn't really, and we'll see why. I put this graph up just to show you how few patients' levels are in the range that we're taught to aim for, which is roughly 350 to 600. So what we need to know about plasma levels and efficacy are two things: sensitivity and specificity. Sensitivity is the proportion of responders that will have a plasma level above the threshold that we choose, and the specificity is the proportion of people with a plasma level above that threshold that will be responders. Now, these two things, specificity is probably the more important because it tells us when to give up on increasing clozapine plasma levels. Now, the interpretations I'm going to show you in the next few slides are based on populations rather than on titrated dose, and that's important to note. So there's always a trade-off between sensitivity and specificity. And you can see in this graph that specificity increases, i.e. 1 minus specificity decreases, and sensitivity decreases as the plasma level goes up. And we've just happened to have chosen 350 as the right balance of sensitivity and specificity. But that does not mean it's not worth increasing levels further. So if you look at the 350 threshold, you'll get a response rate of about 62%, but 20% of patients will have levels lower than that and will have responded to lower levels. So this tells us something important, which is not everybody needs to get above 350 in order to respond. And one of the things I should repeat over and over again, and I apologize if I don't, is that we should always be thinking about the patient and their condition before we think about the plasma level. And we should look at those things together rather than in isolation. If we were to set the threshold at 700, we would get a better response rate. 85% of people would be responders, but half of the patients would have responded at lower plasma levels. So they're being exposed to more drug than they need to in order to gain a recovery. So this means that when we're treating an individual patient, we don't think as 350 as the definite threshold because some people respond below that, and we don't think that it's not worth increasing higher than that because some people respond at higher plasma levels. This is over 100,000 samples from nearly 30,000 patients. These are levels that were measured. This is RCMS, and you can see that more than half of them are above the 350 threshold. These are plasma levels sent from all sorts of patients. They're compliance checks, they're overdose suspicions. What's really interesting in these data is that absolute non-compliance seems to be a very rare thing with clozapine. And I come across people often using TDM to check on compliance with clozapine. My view is that clozapine is its own compliance check, because if you stop taking it, then you tend to relapse. And I don't see really the value in doing TDM simply for the purposes of checking compliance, especially given the very low rate of absolute non-compliance shown in this study. One thing that's often neglected is the sampling time. So you would think somewhere around 12 hours would be okay, but in fact, although the mean difference in level is slightly higher at 10 hours and slightly lower at 14 hours, as you might expect, on the right you can see individual variation. So we need to be much more careful than we are, I suspect, about getting a 12-hour level, and we need to be much more cautious about withholding doses in order to get a trough level, because if you withhold a dose for, say, 3 hours, you are going to get a very low level, much lower than it would have been at 12 hours. And the variation that you get between 10 and 14 hours is much greater than the variation you will see in any analytical method. So all this means that we might aim initially for 350 to 500, maybe 600 for a precisely as we can 12-hour level. And if no response, we know that we can, in an individual, increase the dose according to tolerability. And most people would agree that 1,000 is the point of futility. That is that there's no point in increasing still further. I've put a but in brackets there because somebody spoke to me the other day about a patient they had whose level was 1,100, and they hadn't responded, and they had no side effects at all. And she was saying, is there any point in increasing it? And initially I said no, and then I thought maybe it's worth a bash. So I don't know what happened to that patient, but there are cases, I suppose, where higher doses might be necessary and safe. Now, because we do point-of-care rapid plasma level monitoring, and we can't be everywhere, the expert pharmacies can't be everywhere, we provide people with information that go around with the machines, the point-of-care machines, which explain in simple terms why we're doing TDM with clozapine and what levels might mean and why they might change. So we have a list of when to measure clozapine levels. I think we could probably all agree on this. The one thing that I might entertain an argument about is the last but one on the right-hand side, actually at yearly review. This seems to cause more problems than it solves, in as much as patients who are perfectly well go for a yearly review, have a plasma clozapine level, and it's either high or low, and the psychiatrist flies into a panic and starts changing the dose in a patient who's perfectly well. So I wonder whether that does more harm than good sometimes. Importantly, we list the reasons that clozapine levels change despite the clozapine dose being the same. The most important for this is we don't know. But there are studies that show that intra-individual variation is a very real thing and probably relates to the notoriously erratic, I think it says in this, yes, the notoriously erratic absorption of clozapine, which seems to be affected by a large number of things. Of course, there's changes in compliance, enzyme inhibitors, inducers, sampling time I've mentioned, changing formulation, although there are arguments about that, and a change in assay method. So a point-of-care capillary machine will give a slightly different result from a lab-based LC-MS. The assumption is that LC-MS always gives the true result, but that, as experiments have shown, particularly with clozapine, isn't always the case. And then on the other side of the poster, or at least the second part of the poster, we have some advice on what to do if you get a certain level, given the patient has responded or hasn't, and is tolerating the drug or isn't. So we have these binary definitions linked to particular plasma levels, which help people do the right thing when they get a particular result for a particular patient. I think we've got a close-up of this. So, for example, if you have poor response and good tolerability at 350 to 500, then, of course, you should increase the dose. Right down at the bottom, if you have a patient with a level above 1,000 and they have a good response and good tolerability, then you should probably leave it alone. That might be controversial, but that I believe is probably the best thing to do. And then we've got lots of mentions of consider, which is a bit of a cop-out, adding anticonvulsant or anti-seizure medication. And even after 30 years, I'm still not sure what the right course of action is in these cases. Some people wait for a seizure to occur before adding an anticonvulsant. I think that's probably going a bit too far. But giving everybody an anticonvulsant if their level is above 500 is probably going too far too. So something in between might be better. This is a very old paper from 1997, which is full of errors, but rather proud of myself that I indicated these errors by putting a question mark in brackets. So you'll read in the information sheet for clozapine that it's metabolized by CYP2D6, and of course it isn't. CYP2D6 has almost no role to play in the metabolism of clozapine. And the interaction with paroxetine and fluoxetine is because of 3A4 inhibition. I believe that 2D6 genetic testing is the only FDA-approved test, genetic test for clozapine, which is bizarre because it will tell you nothing at all. And lastly, of course, you know that clozapine plasma levels change according to the patient's condition, particularly where there is infection. Now, I suspect none of you will agree with me on this, but this is what our Lord John Cain says. The clozapine-norclozapine ratio is not a measure of CYP1A2 activity and is not associated with clinical response. So let's have hands up. Who thinks norclozapine levels are useful clinically? Nobody. Oh, some timid half hands. So just a few examples of some ways round using TDM so often. In fact, the first example is about using TDM in conjunction with new genetic testing. So this is a case report from J Clinical Psychopharmacology from last year. We had a patient that we couldn't get a level above 400. The patient was very ill, so we tested the genetic variants associated with the different CYPs, and we found that this patient was a rapid metabolizer via CYP 3A5. So we gave this patient a 3A5 inhibitor, cimetidine, which inhibits quite a few other things as well, but it does inhibit 3A5. And the patient's level shot up, so we gave them a bit less cimetidine, and we got a therapeutic plasma level. Now, that might be interesting from the point of view of the kinetic interaction that we're using for a clinical purpose. But what's more interesting is this patient actually did get better. Their PANS went from something like 110 to below 50 once we got the plasma level to a certain height. Now, you can only do this kind of thing, and we've got several cases now, if you identify the CYP enzyme, which is the culprit, usually for low clozapine levels. So they're extensive metabolizers via a particular enzyme. This method can reduce the need for TDM. This is using assessment of genetic variants of CYPs and NFIK, which is a non-CYP metabolic enzyme with distinct variants. And you can use mathematical modeling to look at the variants that the patient has and then predict what dose would be required to give a plasma level of 350. And you can see on this graph that we make a fairly good prediction of the dose that will be needed. Even this one here, where the dose was 850 required to give a plasma level of 350. So that's one way of being a bit more accurate or precise about the target dose, and you might use TDM alongside that. Most people, I think, use the Rostami-Hodgkin algorithms, which are based on population data. This paper that I'm preparing shows that this method is considerably better in predicting plasma levels from particular doses. So where I work, we, as I've said, have 1,600 patients on clozapine. Most of them are on 3-monthly monitoring. They've been on 3-monthly monitoring since March 2020, from the first lockdown. Those that started 3-monthly monitoring then are continuing. We've got over 2,000 patient years data of 3-monthly monitoring. We can find no safety risk at all, and we hope to publish those data soon. All our blood counts are done as point of care, usually venous sampling. We send nothing away, apart from the odd confirmatory sample that we need from the lab. Some of them we do with a capillary machine, which we've just introduced. This is the HemoScreen device, and we use this for patients who refuse or don't like venous testing. Pretty much all of our TDM of clozapine is done with rapid point of care or with capillary samples using a device that I'm told to tell you is not FDA approved. The turnaround time for the point of care testing is very long. It's 6 minutes. So it's rather different from some of the answers that Jonathan elicited from you, which was many days and in one case 2 weeks. This is 6 minutes. So all our TDM samples, we get the results in 6 minutes. We have a general medical hospital across the road from us, and we also take the machine across there when they have a clozapine patient admitted with a physical condition, so that we can tell straight away whether the patient has stopped taking clozapine or has taken too much clozapine or otherwise has a high level. We're also about to start, and by about to start I mean this week, genetic testing for response, AGRAN, benign ethnic neutropenia, and for dose prediction. That's quite a simple process using a buccal swab, and we get the result back in just over a week. Next 30 years, which I hope to live to see, certainly genomics will be more prevalent in the use of clozapine. I think we can probably crack the AGRAN problem if we use a refined phenotype for genetic studies. All genetic studies so far have used a mixed phenotype model where everybody with a neutrophil count of 0.5 or below is thought to have or considered to have a clozapine-induced problem. And we know that that undoubtedly is not the case, and it probably isn't the case in about 50% of patients. So that means that genetic studies currently that have been done so far could not possibly find the genetic variants responsible for clozapine-induced AGRAN because they're looking, at least in part, at the wrong people. So we will get, I think, identification of AGRAN risk, which will mean that we can abandon blood testing. We'll probably get better response prediction, although I suspect that will never be as good as we want it to be. In terms of formulations, I'm involved in developing an implant which can be removed if the patient develops AGRAN patches. We have problems here with the massive clozapine that is needed to treat somebody properly, but there are ways around that which I won't go into now. And we also use a lot of clozapine IM, simple IM injection. We published a study last year showing that people who start on intramuscular clozapine do better in terms of reduction in bed days and in persistence with clozapine treatment, which is completely counterintuitive. We take a group of people who refuse to go onto clozapine. We say, well, you've got no choice, we're going to inject you. And those people do better than the other people who say, we want you to take clozapine, and they say, yes, okay, I'll do that. What we think is happening is that when we give somebody IM clozapine, we are identifying the patients who we think are most likely to benefit from clozapine. And the fact that they are refusing it probably enforces this view. So when we give IM to people, we are choosing exactly the right people who are likely to benefit from clozapine, which explains why, even though we've forced it on them, they are more likely to be on it 2 years later than people who started it willingly, orally. In regard to tactics, I hope that in the next 30 years, we'll move over to rapid bedside capillary TDM and rapid bedside capillary blood counts, and a reduced need for blood counts, perhaps getting rid of blood counts altogether, even before 18 weeks, if we can develop the genetic test to a better extent. Thank you very much for your attention. I think we're going to have some questions. Oh, yes. Thank you. So, I've lugged these all the way from the UK. They're very heavy, and their weight has made me appreciate that there are probably too many pages. So the next edition will have fewer pages. I've promised myself that. Now, I've got to give these two away. We have at random put one of these around the left forward leg of 2 chairs. So if you are sitting on one of those chairs or are near one, you can have a free copy. Do you want to come up? Thank you. There you go. Thank you.
Excellent. Maria is walking around, so if you have questions, please go ahead and raise those up, and we'll get them up to the speakers.
Oh, somebody else has got one.
Okay. And, here is the email for our virtual attendees as well. So the email address to email all of the questions to. So this is an interesting question, is the cost difference in point of care rapid levels compared to traditional blood levels?
Oh yes, that's a very good question. It's more expensive to do point of care rapid levels. It's not massively more expensive. It depends to a huge extent on how often you use point of care compared to LCMS. You can get to an extent of use which makes the differential quite small. And I think we can bear a slightly increased cost given the better clinical utility of a result that's available in 6 minutes as opposed to 2 days or 2 weeks.
And it would be interesting to hear both of your thoughts on interpretation of clozapine levels 12 hours post-dose when clozapine is given once daily. The variations.
Yeah, I mean, standard time would typically be 12 hours post-dose. Oftentimes, you may have divided dosing where you maybe have a smaller dose in the morning, larger dose backloaded. Some of the TDM studies originally, looked at practicality of lab draws. And so, from the hospital standpoint, we always frame and think about true troughs, right? But these aren't practical in the community, and so it brings up, well, how are we going to get something close to that? So standardized really should be 12 hours. Obviously, if they have a morning dose or it's multiple daily divided, you'd want them to maybe hold that morning dose to get a, more accurate 12-hour. Otherwise, it's going to be probably falsely elevated if, the level's at 1 hour.
Yeah, I think it's quite interesting when you look at the quoted therapeutic threshold for effect of olanzapine, because it's markedly different for 12-hour and 24-hour samples in a drug that's taken once a day. So I think it's important that we standardize clozapine at 12-hour sampling, whatever the dosing regimen.
So how confident are you in predicting dose the required based on a result of a level as a correlation of dose? So I'll show you sort of the equation if you want to see. So if you had a level and a dose, could you predict?
Well, the study I showed you was based on that very calculation. Basically, it's double the dose, double the level. We assume linearity in dose and plasma level within a particular individual. There has been a suggestion that clozapine metabolism is capacity limited at higher plasma levels, maybe when we're approaching 1,000, but there's only a little bit of evidence to support that. So there may be a point where clozapine metabolism becomes nonlinear, but it's not entirely clear.
I know.
There's a question here. When do you use GCSF to avoid stopping clozapine associated to severe neutropenia or agranulocytosis? Thoughts on that?
Well, almost never.
Yeah.
So if you have a patient who's had a true agran, they've had this catastrophic fall, it's gone down to zero, it's stayed at zero until you give GCSF, that's the end of clozapine, usually for those patients. It's, where we do use GCSF is in patients who haven't had that catastrophic fall, probably haven't had a clozapine-induced problem, and we're just doing it to satisfy the monitor that this patient has got a reasonable neutrophil count. Likewise, we use lithium for the same thing, but we almost never use it in patients who've had a real agran.
Someone at Mayo?
Yeah.
Okay. So do you anticipate changes in TDM when using implants or patches or IM, considering first-pass metabolism is minimized?
Yeah, I was talking to this about with some colleagues earlier. The IM that we use in the UK is made in Holland. We know absolutely nothing about its pharmacokinetic characteristics. We've assumed that it's 100% bioavailable. The more we've used it, the more that assumption has seemed to be incorrect. So we tend to give half the dose in IM that we would in oral, but we suspect that it may not be 100% bioavailable. So TDM is useful even when we're using IM. It would also be useful with the implants. But the idea of the implant is that we inject that implant as a way of starting clozapine. So it's a bit like using the IM over and over again, but we implant it and it stays there for 2 weeks and releases its clozapine over that time period. The reason we can't make an implant that would give somebody 2 weeks worth of treatment when they're on 800 milligrams a day is because the implant would be too big. When you think about implants, they usually have things like hormones where the effective dose is in micrograms, whereas clozapine, it's nearly in grams. So the best you can do with an implant is give enough to start somebody on clozapine.
Excellent. That's all the questions that I have from the survey. I want to thank both Dr. Leung and Professor Taylor for being here with us today, and I'm sure they will stay around for a few minutes if any of you want to come up and ask additional questions. And thank you, Saladex, for all of your support in putting together this excellent presentation.